So good afternoon. I'd like to welcome you to the Graduate Institute and the Global Health Center. Some of you who know me, I'm Ilona Kickbusch. I'm the director of the Global Health Center, but as one says, I tend to wear different hats. And in this case, I'm wearing at least two, one as the director of the center and the other as co-chair of UHC 2030. Which I think should come up in a minute, yeah. So you can see here what UHC 2030 is, some further materials on UHC 2030 and the key asks are on their way down from the World Health Organization. So we'll either pass them around as soon as they come, or you can pick them up when you leave the room. So, where did it go to? We just had this description of what UHC 2030 is. Here it is. So you can see that UHC 2030 is a platform, is a multi-stakeholder platform that brings together different actors to promote universal health coverage. It's one of the few initiatives that looks at health in a broader way. There are, of course, many advocacy groups that focus either on specific groups or on specific diseases or on specific interventions like surgery, etc., etc. This is a group that was specifically set up following an initiative that was called IHP Plus, which brought together both donors and recipient countries to support the development of health system strengthening and primary health care. So this was a follow-up organization to say we can only achieve UHC if together we move forward to promote this, both the international organizations, many of them are members of UHC 2030, of civil society organizations. There's a very strong civil societies group, the private sector, academia, some foundations, etc. You can find detailed information on that. And so let's see, yes. So let's start here again. So one of the great challenges and opportunities that UHC 2030 had over the last couple of months was to be a major player in the preparation of the high-level meeting at the United Nations on universal health coverage. That high-level meeting will be in September of this year. And a whole range of preparations are going forward to have the United Nations approve a resolution to support universal health coverage. And one of the ways that process goes is to develop key asks and to, in a way, influence the political focus of this process. And of course, many of the NGOs, many of the players have their own idea of what they would like to ask for. But what UHC 2030 and its steering committee did was to bring the many players together to have a proposal for such key asks, to, through the internet and other means, get input both from stakeholders and from experts to develop a set of key asks. And why was this so important? Because in the context of the Sustainable Development Goals, you know that in SDG 3, universal health coverage is 3.8, has a very central role. The Director General of the World Health Organization always underlines how central universal health coverage is to achieve any of the other goals and targets in the SDGs, and you can see here the way that has been expressed. So this has been quite a complex process. This is just that you can see it. You can also follow up on all of this if you are interested in the details on the UHC 2030 website. But you can see here on the left side the voices that were brought into these multi-stakeholder consultations. Some were online, some were meetings, some were video conferences, etc. And you can see that they took place all around the world, and of course made use of the opportunities of other conferences. Just for example, the Prince Mahidol Awards Conference in Bangkok is always a very, very important meeting place. So one was able to bring many voices together there. So there's a sort of a common theme in the asks that were developed. You can see here, everyone everywhere should have access to quality and affordable health services. This has been a really, really key thing, that it's not just about access and affordability, but very, very seriously, it is also about quality. And of course, since this will be a discussion not just of health people, just in inverted commas, of course, but it's supposed to be a discussion among leaders, government leaders, and other political leaders at the UN General Assembly. The call, the asks are to these political leaders, not to health experts, to political leaders, to legislate, invest, and collaborate with all of society to make UHC a reality. And you can see here the UHC Key Asks that were then developed by the multi-stakeholder platforms. You can then, when you look at the detailed material, see there are 6 key asks. We developed 6 key milestones and 36 action areas on the agenda. And I'll just read out the 6 asks to you, which tried to summarize this highly, highly complex undertaking. One, of course, is to ensure leadership beyond health. We all know that health ministers alone will not be able to achieve universal health coverage. We know that finance ministers are critical. We know, depending on political systems, presidents, prime ministers can be absolutely central. So it's very, very important to ensure this political leadership. But what was very important for us when formulating this is to say the political leadership means that we consider universal health coverage a social contract, something that is absolutely critical to also bind a society together. It's an expression of solidarity between people who participate in a common health system. The second ask is, of course, then also linked to the social contract, because a social contract always implies sharing, it always implies redistribution, it implies social justice, it implies rights, and once you have a contract, you have rights. And therefore, this slogan of the SDGs, leave no one behind, and the need to ensure that the most vulnerable also have access to universal health coverage. We have, as the second ask, leave no one behind, pursue equity in access to quality health services with, again, very critically, financial protection. Because, of course, the key message of UHC was and is that nobody should fall into poverty because they have to pay for health services. And as you might know, 100 million people every year do fall into poverty because they have to pay for health care out of pocket. So the combination of 1 and 2 is very, very important, because a social contract implies that you leave no one behind. UHC is not just a strategy for poor people. It's something that we work together as a society to achieve healthcare for all. Our third ask focused very much on the need that if you have a social contract and you have rights, you need legislation and you need regulation. This has to be part of how you govern a country, how you govern health, and so create a strong enabling regulatory and legal environment responsive to people's needs. And this, of course, then also includes that people, no matter of what sexual orientation, no matter in what racial relationship to the majority society, etc., everyone has the right, and this has to be legislated. This has to be your right before the law. There has to be a rule of law. I've already said, ask for, uphold quality of care, build quality health systems that people and community trust. We also know this from the education debate, that just having access to education is not enough. You've got to learn something. It's got to be quality. And the same is true for health. It's not just enough that you can go and have access. You've got to be ensured good care. You've got to be ensured quality. And this is also important. Some of you, just very few of you, might be old enough to remember the primary healthcare movement, 1978, Alma Ata. And one of the big problems that emerged from the primary healthcare movement, that many people considered it poor care for poor people. And this is definitely not something we want to even come close to when we discuss universal health coverage. Everybody needs to have access to quality care. And the trust element is also important. We built that in, particularly given the experiences with community health, with Ebola, etc., where people, because they don't trust their government, they also don't trust their health system. And these are very important issues, particularly also if you think that in many countries there's a fair bit of corruption in health systems, and therefore in many cases you can't even trust your professionals because they are corrupt. So we've mentioned, if you read the text, we've mentioned a number of these things very explicitly. Of course, money is critical. Invest more, invest better, and public financing plays a highly important role. There are some interesting new studies also from the WHO that it's very positive that public financing has increased in many countries, but of course it's still a far, far way to go. And at least 45 countries, what we tend to call the fragile states, still have significant problems. Actually, their public financing has gone down compared to many middle-income countries. And these investments, of course, need to be harmonized. And the sixth ask, I guess, reasonably obvious for a multi-stakeholder initiative to say, we've got to move together. We've not got to, fight against each other and either say, one disease is more important than the other, and UHC means we've got to, and you will see that what we tried very hard is to keep this spirit of solidarity in the text. So we don't have long lists of vulnerable groups, we don't have long lists of diseases, we don't have long lists of interventions. We say, if we get a good universal health coverage, if we get a good system, these things will be taken care of. If we have, good legislation and an aspect to leave no one behind, then the vulnerable people will be part of it. We have those milestones. I'm not going to read those out now, but I ask you to look at them. And you can see that they focus, that's the only thing I'd like to highlight, on 2023. Some of you might know that there have been a number of health meetings at the United Nations over the last couple of years. Just last year, tuberculosis and non-communicable diseases. The decision now is that there should be no further health meetings at the UN until 2023. And jointly then, maybe in a whole health day at the UN General Assembly, the world would report back to what have we achieved in relation to these challenges that we've set ourselves. And therefore you will see that goals are set for 2023. And that's the step then to 2030, when we should be reaching the Sustainable Development Goals. You can see here some of the key milestones. I think, you know, some of the panel will come back to that. The multi-stakeholder hearing, as you can see, just took place a week ago. Some of the people on the panel were there. They'll tell us directly how they experienced it. But there's, you know, still a fair bit of work to do until we have a political declaration at the end of September. What is important that I'd like to highlight is that, of course, there is a lot of political action also around this. So there's not just the direct road and process to the UN General Assembly, but, for example, there is the G20 summit, and Japan, that is the chair of the G20 this year, has made universal health coverage a priority. And it has already taken initiatives to bring together health and finance ministers to meet on this agenda. So you can see other summits, G7, G20, are important in this regard. And we hope that we will get a strong political resolution, maybe as we discuss on the panel. There are indications that it's not going to be that easy, because not everybody thinks universal health coverage is a great idea. And therefore, some of the negotiations are going to be quite tough. In this process, there is also the so-called co-facilitators of the process. And 2 countries are co-facilitating: Thailand, one of the spearhead countries of universal health coverage, and Georgia. So these are the links that you have if you want to find out more about UHC 2030, the asks, etc. If you want to get into contact, if you want to tweet from this meeting. And you can see here a wonderful umbrella. How did that come about? In general, the umbrella is the symbol of the universal health coverage movement. But one of the participants from the UHC 2030 team took all the statements and then checked what priorities actually came from the presentations, and that's just reflected in this umbrella now. There's, we might actually keep the asks up here while we discuss, because I'm sure some of the discussants will come back to them. Maybe one more thing that I need to say, excuse my voice, and I just have to cough, is that there was quite an initiative from a movement that I belong to with partly another hat, and that is Women in Global Health, who felt very strongly, and I think correctly, that the whole issue of women, given the fact that they are the majority of the health workforce, was not reflected sufficiently in the asks. And having worked under pressure on that, we had to acknowledge that. So what we are presently discussing is whether we possibly add a 7th ask, which is how Women in Global Health have presented it, to link particularly this gender dimension very strongly to these 6 asks. So that's a short introduction. I don't want to take up any more time. It's already a bit more than I planned to say, but maybe not all of you are so familiar with these processes that maybe that has been helpful. If I could ask the panel to come up now and take your seats, please. There's a just sit here, Jemilah. Thomas, sit in the middle there. Ranieri, why don't you come here? Come here, and this is mine. Okay. Yeah. I don't know if I'll even sit, but what we always do here is when you come, you get an extra sheet that actually introduces the speakers to you in more detail, so we don't use up the time to give, all their distinguished achievements. So I'll just call on them as we ask them to reflect on these key asks and on the high-level meeting. And I might add that colleagues from the UHC 2030 Secretariat are here as well. So if afterwards you have some additional questions around this, they will be very happy to respond to some of your questions. So first, it's my pleasure to ask Dr. Ranieri Guerra to give his reflections from the side of WHO. He's Assistant Director General at the World Health Organization and the chief diplomat, so to say, for the UN high-level meeting on UHC. And so, Ranieri, if you could give us some impressions from this multi-stakeholder meeting, what WHO thinks about these asks and how you think this process is going to move forward. I indicated we all think it's going to be not that easy. So what do you think?
Thank you, and good afternoon to you all. Thank you, Ilona, for this opportunity. It's not easy. It's a tough agenda that we have in front of us. It's also a very crowded agenda. During the same week, at the end of September, the same day, we will have the high-level meeting. 1 hour later, in the same UN building, we will have the climate change symposium that is being called by the Secretary General. The next day, we will have the SDG discussion. The next day, we will have the financing for development. And finally, at the end of the week, we will have the small island case that will be brought forward. So as you can see, there is a competition of different aspects that in a way for us will converge into the universal healthcare agenda. For us, as you know, it's essential, it's critical, as it has been said. Tedros has defined that as a prerequisite for everything to happen. Unless we achieve that, we will not be able to implement fully the general program of work. We will be left behind into the big issues that will go ahead, and the partnership, the complex multi-stakeholder ecology that we need to build will not be built in time to achieve the SDG goals. If you check in the WHO website, you will find a number of indicators and trends that clearly indicate that by 2030, unless we change and we improve the pace of achievements, we will not be able to achieve what the key indicators in terms of maternal mortality, infant mortality, nutrition status of children and others have been set. There is no doubt that, as I said, it's a crowded agenda. It's very complex. It's also complex because we will have to move, as it has been said, from a kind of meetings among friends and among competent people within the health system into something which is much more complex and a higher level. Our interlocutors will be heads of state, prime ministers, chief of cabinets, those who can decide from a government perspective on what the entire government will have to align for. So that's not that's not a simple issue. There are complexities around some of the dimension of the discussion. For instance, and to be very frank, the issue of sexual and reproductive rights that few countries may not agree upon, the issue of public financing as a priority, which some of the countries will not agree either, the issue of population on the move, migrants and refugees. As you know, there is a strong debate for the adoption of the Global Compact in the UN system last year. This year, at the WHA, we represent the Global Action Plan for Migrants and Refugees. We passed through an extremely difficult iterations with member states. There are a few member states who, for pure ideology, in my view, do not agree on the compact and on the issue of rights of migrants and refugees, thinking that migrants and refugees can be left behind, as it has been said. There are a few areas of work that we really need to address in these couple of months that we have in front of us. The process is that the two pen holders, Thailand and Georgia, will consult extensively. They will be here on the 9th of May. They will meet member states at the WHO. They will try to present their views and to understand from the audience of member states' missions what the key issues may be that need to be reflected with the right language in their proposition. They will have to draft something, a zero draft, that will have to be discussed and negotiated. They will be ready to start negotiations by mid-May. That will take us definitely until the end of July, if not beyond that. So we can expect to have something more structured by the end of July, beginning of August, for the President of the General Assembly to start reviewing it. The peculiarity of this high-level meeting is that it is not owned by the UN system. It is a member states-driven process which is chaired by the President of the General Assembly. And to give you another idea of how complex the situation is, the President will change by July. So the person who has managed the process so far will have to hand over everything to the newcomer, and the newcomer will have to make sure that all the big issues are captured and something which has been built is not destroyed. There are issues around funding, of course. There are issues about human resources. There are issues about infrastructure and technology that need to be addressed and to be addressed very clearly. Around infrastructure and technology, of course, we will have innovations and incentives, the fiscal reform, and everything which is pertaining the health system by and large, and all the characteristics by which health systems, which are different from one country to the other, can contribute into this achievement. And I will stop here.
Yeah, we can pick up some of those issues afterwards. Thank you very much, Ranieri. And that already gives you an additional idea of the complexity of it all. I'd like to pass on to Jemilah Mahmood, the Under-Secretary General for Partnerships of the International Federation of the Red Cross and Red Crescent Societies. Jemilah, your interest in universal health coverage, I think, relates also to some of the groups that Ranieri has alluded to, and I believe, of course, especially the Leave No One Behind agenda and the expansion of not only fragile states, but fragile settings. So how does that relate to universal health coverage? How can we make sure, in your view, that this is considered appropriately? And I'm going to jump up here now.
Sure. Thank you very much, Ilona. It's a real pleasure to be here with all of you. First of all, I just want to congratulate the people who are really working to push this forward, because it is crucial. It is going to be difficult and complex, but it's necessary. And just to say how much we believe that the universal health coverage agenda is so critical, we've actually incorporated it into our next 10-year strategy. So you have big supporters in the Federation in terms of UHC. Why do we say it's important? Well, we are a membership organization. Some of you may know a bit more about us, but let me just tell you we are in 191 countries as our national societies of Red Cross and Red Crescent. We are auxiliary to government, and what does that mean? Well, that means basically, in simple words, the government is responsible, but where there are gaps, we fill it. So, and therefore, you know, the health mandate is a big mandate for us as a federation. We celebrate our 100th anniversary. In fact, yesterday was our 100th birthday. So, we've had this long experience. When we look at the different areas and the R's, we particularly identified and aligned ourselves to 2, 4, and 6. And I really welcome an additional 7 of women in healthcare, because women like us, Ilona, who have been really, in the healthcare, both of us come from a medical background as well, that a health background, that, it's so important to really position the role of women as well. Now, in terms of leaving no one behind, as you mentioned, a lot of the discussions have now been basically around conflict settings, which is appropriately so. Many people are affected, and there's a lack of access to healthcare. But there's also, growing. In fact, the figures are something to the effect of 160 million who are also affected by disasters as a result of natural hazards, and we know that a lot of this is driven by the climate change. And I think we can't exclude that. The other thing is, as well, is pandemics, big health crises that are now becoming crises on their own as well. And where we see our value is really in the volunteers that we have. We have about 13 million volunteers around the world, and it grows in a crisis. It can escalate quite rapidly. And the other issue around universal healthcare is the non-formal health sector. So we're talking about the volunteers who actually are activated in crises, who actually perform a lot of the duties in reaching that last mile in healthcare. And this therefore brings me to the whole issue around community-based healthcare, whether it's from surveillance to actually delivering primary healthcare or first aid, or other forms of healthcare that are, as we say, are rights of every human being to that dignity and the right to healthcare. If I can pick up on Ebola, as you mentioned earlier on as well, that, the duty of, for example, safe and dignified burials is sometimes overlooked as a very crucial element in healthcare, because from the lessons from Sierra Leone and the West African Ebola crisis in 2014, it was the safe and dignified burial of people who were victims of Ebola virus disease that actually stopped the transmission of Ebola further than where it was. And I think that's something that's extremely important. What we also feel very, that we would like to see that is very much a people-centered approach. Yes, you have governments who will eventually make those decisions in September, but for this universal healthcare to really succeed, we've got to engage, the communities themselves and also the different stakeholders in understanding what exactly we are doing. So on that, we are very pleased to be partnering with UN AIDS, as well as the Civil Society Engagement Mechanism for UHC 2030, to run 14 country advocacy programs, where we will be convening different stakeholders, including people from communities, including civil society, government, and so on and so forth, to some of these dialogues. So I'm just going to pause there, perhaps to say, just as this is, I think the tagline was everyone, everywhere. Our approach in the Federation is everywhere for everyone. So very much aligned with UHC 2030.
So thanks very much for that. I'd like to give the floor now to Mr. Uwe Petry, who is the head of the Economic Affairs Division at the Permanent Mission of the Federal Republic of Germany here in Geneva. Some of you might know that Germany already with IHP Plus was incredibly active to continuously, I'd say over the last 20 to 30 years, support universal health coverage under other names. Health system strengthening, of course, and the link into social protection. And Germany is also one of the countries that is financially supporting UHC 2030. So, Mr. Petry, maybe you can share with us some of the expectations that Germany also has from this high-level meeting, and any particular challenges that you see at this stage, please.
Thank you very much, Professor Kickbusch. Dear audience, it's a pleasure being with you and discussing this very topical subject at a timely stage. you referred to recent history, IHP Plus going to UHC and Germany's support for it. When I was thinking about our role today, I would reach even further back. Germany was one of the first countries to introduce a social security system at the end of the 19th century, and it was this then Chancellor Bismarck. And in a way, if I would like to make a link to our times, Chancellor Merkel was the first politician, high-ranking politician, to introduce the subject of health and to introduce a health ministers meeting into the German G20 program a couple of years ago. And this initiative has been taken forward by others, including now by the current G20 presidency of Japan. So Germany is very much involved in the global health agenda. We feel that global health has its place in multilateral efforts, and questions cannot be solved without multilateral cooperation and a multi-stakeholder approach, of course, also. We are looking at the UHC efforts and especially at the asks with a very favorable eye. We think that the questions, the asks, are very pertinent. If you look at their genesis, they have been created by relying on very valid sources, decisions, advice by specialized agencies. So all the questions we feel are very relevant, and we are ready to support them. Of course, at the forthcoming World Health Assembly, there will be discussion. There are two resolutions, one on UHC, the other on primary health care. We will have, I hope, a very fruitful debate amongst member states on the issue, which will further clarify the way forward. But we are very supportive and looking forward to the organization of this high-level meeting in New York, and are ready to contribute to further shape the draft declaration we all aspire to. If I had to point out certain elements, I would first and foremost point to two asks, maybe a link between Ask 1 and Ask 6. It is well known that Germany sees global health as an essential part of the Agenda 2030, which it is, but it has to be stressed time and again, we believe. And in this spirit, so to speak, we are also an initiator, together with Ghana and Norway, of the Global Action Plan for Healthy Lives and Well-being for All in order to implement successfully SDG 3. It's a collaboration between 12 agencies, and it shows you that we are behind the idea of fostering political leadership even beyond the narrow realm of global health only, but involving also other sectors, economic issue, financial issues, social questions, gender, and whatnot. And then it's, of course, also a symbol for the Ask 6 move together. We have to bring people, we have to bring groups, we have to bring institutions together. 12 institutions under the umbrella of this Global Action Plan. This is already an initiative pointing in the direction we want to see. All in all, as I said, we are supportive. I would like to maybe emphasize that it is very important for us to get everybody on board, leave no one behind. And of course, gender issues are important, sexual and reproductive rights and health issues we believe are crucial. Migrants, we are among those who unequivocally support the global compacts on migration and on refugees. So we would see a strong need to further develop the health agenda in this regard. And then, of course, we are ready to look into financial questions, it is absolutely crucial that we are innovative in this regard, and that we also strengthen ownership of member states also under the Addis Abeba Action Agenda, and of course assist certain countries who are still in need and cannot afford to finance everything by themselves, but then also have a mid or long-term strategy in order to have an exit from external assistance into sustainability of financing the health systems. Maybe I stop here.
Thank you very much, and thank you very much for highlighting the finance issue again. But just to indicate to you how difficult this is going to get, some of you might have followed in the press that Germany, that presently shares the UN Security Council seat with France, has just put forward in the Security Council a resolution on rape in conflict, trying to ensure significant legal consequences for people who use rape as a means of war. And that actually, this discussion got very, very, very difficult because a group of countries felt very strongly that the call in that statement and resolution for supportive services for women following such rape could be interpreted as providing abortion services and therefore not being supported. And so this gives you an indication that already if you're just using the word health services, depending who reads the word health services and has an intention of interpreting it in a special way, and that these things, and I'm glad to hear so many of our panelists referring to health and sexual rights, that this is going to be one of the most controversial areas. That's also going to go through the universal health coverage debate, the language that is going to be used. And I think without, having planned it that way, but the discussion in the Security Council, the vetoes, the pressure exerted is an indication of ideological interests that are going to move through this debate that Ranieri also referred to. So we have two more voices here from the panel. We'll hear first from the World Economic Forum, Dessislava Dimitrova. She's the lead of health systems and joint ventures and very active in the UHC 2030. Please give us your impression of the discussions.
Thank you, Professor Kikbush. It's a pleasure to be on such a distinguished panel and to see so many people interested in the topic. It's really exciting. The World Economic Forum is involved in this because we are the host to the private sector constituency of the UHC 2030 partnership. And what this constituency does, it's a pretty young one. It's interesting that when the partnership was created as IHP Plus and then as UHC 2030, it was a multi-stakeholder partnership and focused initially on health system strengthening and then on UHC. It was missing one important voice of the private sector, and it seems that in the previous era, it was almost as if the private sector was not part of the global health dialogue. So we'd like to really commend WHO and the World Bank and the team of UHC 2030 for welcoming the private sector to be part of the conversation. And the vision of this constituency is to be the go-to platform on any topic related to the private sector and UHC. We know that the private sector is so heterogeneous. There's the informal sector, there's the formal, there's multinational corporations. They're focused on pharma, medtech, disruptive technology. So what's really exciting in the UHC movement, in contrast to the previous high-level meetings, for example, is that now we can have one unified voice from the private sector through this constituency. So it's an important channel. And we focused our work this year on three things. The first one is how do we build trust? Because we really cannot move forward and move together as the sixth ask is calling on us unless we have great trust. The second one is to just the previous point that Professor Kickbush was making, how do we build a common language? And even as things as simple as, one might, in the first call with the constituency, people said, well, what is universal health coverage? Is this health insurance? So understanding what we actually mean by the same language is really important. And we saw even in the Alma-Ata declaration, PHC and primary care, we never came to the alignment of the words. So understanding the words is extremely important after building the trust. And the third one is now that we have trust and that we have common language, how do we move forward and move together? So on the trust, even thinking through as some of the companies were signing the compact of UHC 2030, a topic that came up was, well, we acknowledge that health is a human right, but when you're a private company, sometimes that might mean that we need to give up our intellectual property rights, and we've seen that in countries. So this is a very major issue, but understanding in this particular company, they were able to convince their legal department that being part of the movement and that health is a right doesn't necessarily conflict with their particular company policy. So I think being part of a conversation really helps understand what our conflict of interest is, what our constraints are, and working together. So coming back to the 6 asks, the process, we really want to commend UHC 2030, the co-chairs and the secretariat for making it extremely inclusive. Professor Kickbush walked through all the dialogues that have taken place to come up with these 6 asks, and for the first time, really, the private sector has been asked very directly for their feedback on the high-level meeting declaration that would come out, and that has really helped in building trust and building a common language. In terms of the concrete asks, ask 4 through 6, private sector partners find they can really align on, especially the one on invest more, invest better. The discourse has for a long time been let's give more money, and now for the first time we're talking about how can we actually spend this money better, because we know there are a lot of countries that spend a lot but they're not efficient. So, and that is that actually discourages ministers of finance to the first point. How can we bring other ministers and heads of state to the conversation if they see that we're spending the money better? And now there are a lot of new business models that are coming that are aligning private and public sector interests, like managed equipment services, value-based healthcare, etc. And the third point I wanted to make was around a reflection on the multi-stakeholder hearing that was last week in New York. One that was very striking was that a lot of the groups that were focused on diseases like TB, HIV, etc., malaria, they seem to all see UHC as an umbrella under which they align themselves. So I find this to be a great opportunity moving forward for us to take a more health systems approach rather than continuing in silo. And I think this is something we really need to carry forward after the high-level meeting, because the high-level meeting is where the declaration would come, but the action would come after it. So figuring out how we can serve as the umbrella to all the different disease efforts would be an important one. And the second one also I found really so many coherent voices. So the movement really was an umbrella to all the different silo stakeholders as well. So important to keep that momentum with the 6th one. And final one is let's make our voice count. We found Gitinci always, who's the other co-chair, repeated that, and I think each one of us has a lot to contribute. Thanks.
Thanks very much, and thanks for also reflecting on the meeting itself. And it's my pleasure now to give the word to Thomas Schwarz. He's the Executive Secretary of Medicus Mundi International. Some of you might have already heard his, no, not heard, but read his blog reflecting on the high-level meeting. But Thomas, over to you. What were your impressions? What do you think about these asks and how to take all this forward?
Thanks. I will not be the unified voice of civil society here. I think I'm rather invited to disturb the party. And this is what I'm going to do. I will talk about 4 points about UHC as an umbrella, about the movement, about multi-stakeholderism, and I will find with social contract, and that's the most important for me. I quote this Key Ask document, which says, the UN high-level meeting is a major opportunity to mobilize the highest political support for uniting other health agendas under a common theme. I kindly disagree. I think the good news of the current focus on universal health coverage is that the health system and the politics and economics of health care are back at the center stage of the international debate on access to health, after too many years of working in vertical silos to fight against diseases or promote the health of particular groups. I could not be happier about this, and also love the surprisingly strong political and public health language of this document. Please read it, please go through it, sentence by sentence, it's worth it. I think this document will be much longer on my desk than the political declaration of the high-level meeting. And that's not good news, by the way. And yes, if properly designed and implemented, UHC is the key contribution of the health system to achieving universal access to health. However, the definition and iconography of UHC as an umbrella to unite all health agendas is intellectually, politically, strategically wrong. It's misleading. The umbrella mainly hides the free side on the social determinants of health. And here I quote WHO. The conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. The social determinants of health are mostly responsible for health inequities. The unfair and avoidable differences in health status seen within and between countries. Everything is UHC now. Hashtag health for all. This does not allow even a sound conversation on the core of health systems and public health issues related to access to health, but leads to an overloaded and distorted discourse. Ask the Russian delegate who was there at the multi-stakeholder hearing. He did not just understand us. Talking about the movement, UHC 2030, key asks from a movement. Well, when we joined UHC 2030 2 years ago, and later on also its civil society engagement mechanism, we were quite clear and explicit that we rejected this movement narrative, and we still do. I've been engaged in social and political movements all over my life. What I learned is that in being part of a movement or not, there is a difference between being existentially affected or being just there in solidarity. Both is important, both make sense. But what I know for sure is a social movement for health is a people's health movement. It cannot be organized top-down with a secretariat hosted by WHO and the World Bank, and with interactive multi-stakeholder conversations and a civil society engagement mechanism. So call UHC 2030 as you like, but not a movement. And yes, let's talk to each other. That's fine. Let's think about what can we all contribute, learn from each other, get better organized. Then this makes sense, particularly in the production of global public goods, and there would be many. Quickly about multi-stakeholderism and multi-stakeholder platforms and mechanisms. I participated in that New York interactive multi-stakeholder hearing in view of the high-level meeting, and I realized once more that some people do not even hear anymore how weird this sounds. When I was, at the end of the 1990s, at the first time invited by Novartis for a stakeholder dialogue, I first had to look up that word in my vocabulary. I didn't know it. Now we have all taken over the stakeholder narrative and paradigm from the industry. We have become used to it, as we are used to talking about partnerships and inclusiveness. I do not see much good in this. Multi-stakeholderism is mainly an instrument of manipulation and cooptation. Pretending that we can achieve health for all, just being nice together and doing the things in partnership, blurs fundamental differences in positions, roles, responsibilities, power, interests of the different actors. At the end of the Astana conference, and I was there too, I walked out of the room and the crowd of health ministers and industry representatives and global health initiatives started to sing "We Are the World." Health as a social contract. Health as social contract at the top of this agenda. I insist on this. At the hearing in New York, we heard the WEF representative saying that countries could learn a lot from private sector, for example, by seeing patients as customers. Still in New York City, civil society colleagues promoted the idea of asking the global health initiatives, such as Gavi or the Global Fund, to facilitate and convene dialogues between national governments and civil society and to make good practices in doing this a condition for countries to get aid. And preparing today's meetings, I stumbled over an announcement of an event at the institute here with the title, "Is Democracy Good for Health?" Come on, let's stop this nonsense. The fulfillment of the right to health cannot be imposed to a country, nor can access to healthcare be organized as customer relation. People are not customers and not beneficiaries. They are people. They are sometimes individuals, sometimes patients, sometimes organized in communities or in other many forms, and they are the right holders. And the state is the duty bearer, a role that goes beyond regulation and stewardship of the health sector. Under international law and in most of the constitutions, states and governments assume obligations and duties to respect, protect, and fulfill the right to health of their people. A well-governed and responsive and caring state does not come easy, and neither does universal health access to health. They are the result of tough societal negotiations. We can call it a struggle for the right to health, and too often this struggle is lost. Just the facts that countries will go to sign the Global Compact of UHC 2030 or the political statement of the high-level meeting will not change this. Please read the editorial, the document published by Richard Horton last week in The Lancet about the social contract, which is the core in every country. And I end with quoting my friend Amit, who passed away last year, saying, "The struggle for health is a struggle for a more caring world." And this is the responsibility of every society. Thank you.
Thank you very much, Thomas, for doing what you always do, pulling us back to the essentials. And I really think it's critical, and those of you that worked with us on the asks knew how critical it was to get this notion of the social contract into those key asks, because it at least tries to reflect many of the things that you indicated. And we heard from Germany, how long it partly takes until you really get such a social contract fully established in your society, what social movements it takes, what fights it takes at the political level, what difference of interest it brings with it. And that, of course, as Ranieri already alluded to, the duty bearers, the countries, are not necessarily of the same opinion, and not all duty bearers consider it their responsibility to establish such a social contract. So it continues to be, and maybe in an interesting way, this discussion around universal health coverage will actually not allow us to glean over some of the differences that actually exist. It seems to me to be much easier around specific diseases to do that than to do it around a system that you need to establish, that needs to be sustainable, that needs to be financed, and that needs to be supported by the whole of society and trusted by it. So I wonder if the other people in the panel would like to reflect on exactly that social contract issue, and in this case, particularly also the expectations towards governments as they move forward in this debate at the high-level meeting. And maybe since WHO will also be discussing this at the World Health Assembly, what signals, what vibes are you getting, and what are WHO's expectations of its member states at this stage? Ranieri.
Yeah, thanks. Well, again, the discussion is even more complex because now we got into something which can define UHC as a tool and not as an end. The end is to improve the health conditions of all. To this extent, we focus specifically on other controversial areas like the economic determinants, because talking about social determinants in a kind of ethical environment is just fine. But when we got into reality, economic determinants may be the ones that we need to target specifically, because they come with the responsibility and accountability of heads of state and governments, because they need to build a regulatory system, a regulatory environment, which is not only ethical, which is viable, and which does not stimulate extreme barriers, as it has been the case in several member states. The big thing is to agree, or to make heads of state agreeing on a different governance that comes with a different accountability system. And this is something that, in theory, is very easy to say. We know how to do it, but in practice, it calls for a legislative initiative sometimes, which is strong and tough, that aims at creating this kind of reciprocal accountability, if you wish, by government to civil society, by civil society to government as well, by the private sector, whatever the private sector is, because that's a combination of different entities, in particular the private for-profit sector, into something that may be willing or may not be willing to adopt and to accommodate. I've made reference, for instance, talking about one of the neglected areas, which is occupational health. I made reference to the social responsibility of the private sector during the HIV epidemic, where UNH, WHO, and others managed to have the private companies endorsing a code of conduct that they fulfilled. This, with the time, has vanished to some extent and has not been extended to cover all the different aspects of occupational health. Think that there are millions of people dying every day because of their working conditions, which are totally unsafe. Think of the work which is unofficial, drawing on migrants workforce, for instance, in different countries. In some countries, universal coverage has been achieved. That's the official version. If you look at that, it has been achieved for the residents. And the residents in some countries account for 15–20% of the whole population. So this is the kind of situation that we need to address, and we will do that. We will do that. But remember that WHO is not a civil society-owned organization. It is a member states-owned organization. So we really need a strong voice by the civil society to make governments accountable and to accept our proposal for a new governance system, for a new accountability system, which is based on quantitative measurements of the level of achievements, of the level of success, because the framework for accountability that we propose comes with clear indicators on impact. And unless we are all converging into that, into producing a new metrics, we will not be accountable. We will not know what happens and why it happens, or why it doesn't happen.
Thank you very much, and thank you for highlighting this issue of also of accountability and according to what measures And some of those milestones there hoped to address some of those issues as well. I'd like to go to Mr. Petry, if I might, because one of the important things of the SDGs and, of course, also the universal health coverage debate is that it's not only for developing countries, but that it applies to Germany as much as to France, to the United States. And if we look at the European Union, actually the health systems in some of the European Union members might be worse off than in some Asian countries, for example. So could you say a word or two about how the universal health coverage agenda is also understood reflecting on a developed country such as Germany, a region such as Europe, and how that will possibly be addressed in the high-level meeting?
Thank you. I think it's a very pertinent point to say that under the Agenda 2030, all members, all actors are on the same level, in the same boat at least, and that we can learn from each other, and that developing has changed a little bit its significance. It's not bringing those who are underdeveloped, as it used to be perhaps in the past, to the level of those who are already developed. But given the challenges of today's world, we all have to further develop. And this goes also for health systems in richer, I would call them like this, richer countries. They also have their own challenges. They have to move on. There are, for instance, talking about moving, there is, of course, a movement within Europe. We have the migration issue in Europe, so we have to face new people we have to care for, new burdens, so to speak, for our health systems. We have to find within the European Union a common approach, at least this is what we should aspire to, and make Europe, how to say, a unified area where we have common standards and common values also with regard to health questions. And we still believe in Germany that, of course, and I would subscribe to much of what had been said by Mr. Schwarz. A social contract, yes, but a social contract has different actors, and the state is one important actor, and it still needs the political will. It still needs a strong leadership to go beyond sectorial health issues and to look at the broader picture, to also look at social inclusion, to look at migration, to look at gender, reproductive health, and so on and so forth. So the state, government and states are important actors, and this is what we would like to further strengthen and seeing strengthened by the political declaration we are expecting from New York.
Thank you, Jemilah. Maybe that's a good point where you can also come in, because you work in so many environments where the state is incredibly weak. Yeah. And so how do you think one can help move that agenda in that context? I was incredibly shocked recently that one of the countries that is experiencing significant health problems at the moment, and where there's a big effort to collect international money to support that country, at the same time has been spending $8 million to get close to President Trump in Washington for advisory services. So, there's very difficult issues around politics, corruption, priorities, authoritarian states, etc. So how do you deal with that?
Well, first, before I go to that, I just want to say that, what was said about, it's about people. And I think that at the end of the day, you need to have the political will, and the political will drive how finances are being distributed in a country, and whether or not there's going to be buy-in for this whole approach or rights-based social contract approach. But I will also say that all of us are not naive, and every different context is going to be very different. that, you know, there are, I would say, governments who probably don't care about the people, and that, you know, we have to be aware of this. And I'm thinking about, you know, also one thing that maybe we've not discussed about is the voice of people. I mean, look at Greta Thunberg, who's, you know, marching the streets and speaking to parliaments, and every major leader in the world now wants a selfie with her because, you know, she's saying things which are actually very painful to hear, but she's managed to get the momentum of social kind of support, a universal social support, not just within her country. So I think this is where, you know, the voice and the, you know, the communication and the buy-in on issues around the social contract or universal healthcare or, you know, the rights of people will become critical. And I think we've got to think through this. And I don't think, to be very honest, we are sophisticated enough sometimes. I'm talking about we, meaning me, an older person. I'm thinking that, you know, we need to get the young people on board here to really rethink some of these things. And on, you know, fragile context, but not just fragile context, 10 countries actually are the ones that are experiencing protracted conflicts, and 15 countries carry the burden of long-term crises, right? So you might also erode the economic reserves, or rather the development gains of many countries, and push them back into a situation where how then do they make those judgment calls, and how do they decide where finances are directed to? So I think this is where, you know, if I speak for the Federation, we have a view that it's so critical that civil society plays this very important role, that it shouldn't be a gap filler, but it can be, the advocacy role, I think, has to be taken very, very seriously. What we are trying to do, at least for the Federation, is how do we play at that auxiliary role better in influencing our governments, our national society governments, that, you know, these things are critical. And with all governments, you have to show them political gain and economic gain. So we've got to join up the dots here, and this is where private sector and others are going to be quite critical.
Dessislava, you already indicated that there was a certain amount of nervousness in some of your constituents. You know, what does this mean? How does this impinge on, you know, like you mentioned in particular, intellectual property, etc. I think you also indicated, which I do believe is very important, that we understand more clearly, particularly around health, the very many different parts of a private sector that exists. And of course, even in countries with a social contract, many of the health professionals are actually, you know, private sector if you take it seriously. So I wonder what kind of debates you are having around that, you know, clarifying, you know, these are the very different parts and the different voices of the private sector. And also what often surprises me to actually concede that not all parts of the private sector necessarily agree about universal health coverage, particularly if we were to enter the areas that Thomas referred to that are more related to the determinants of health or the working conditions that Ranieri just related to. Do you have that really open debate within the private sector around these things?
Well, currently the constituency, as you know, is a bit very heavy on pharma companies. So I think that the conversation would change dramatically as we have more health insurance and health service delivery, and especially sort of what the World Bank calls disruptors, the ones that would innovate the way service delivery is done to reach more people. A lot of the conversation that we've been having has been around please trust us, let us start a dialogue and let us work together. And I find that this model of value-based healthcare to be a very good one, where companies like Novo Nordisk or others that are producing certain product, like say, let's talk about diabetes, don't pay us for the insulin that we give you, but pay us for the health outcomes that you have. And I think this is a good risk-sharing arrangement in which in which private sector can also step up and the government can commit, because what we hear a lot is we want to commit, we want to contribute to a country's health system, but the minister changes every 1 year. We have no idea what the national plan is. We don't know what their priorities are. At the same time, we hear from governments when they're saying, oh, they take this one innovation, they put it in that neighborhood, put all their resources there, and they say it works without having consulted with us. So I think starting the conversation is really important to be able to move together.
Thank you, and you actually pick up what Ranieri indicated, that if anything, if this debate allows us, and your blog also referred to that partly, Thomas, allows us a more open discussion around what this really is about, and that we don't cover up the differences, but really try and move forward and say, you know, it needs these tough political decisions to be able to really make a difference. And if we can measure some of those elements, then hopefully using the kind of, let me call it, real social movements that exist to, you know, also push for significant accountability. And some of that, and a lot of that, goes with noise and with conflict. And, you know, I was wondering if, you know, the UHC social movement, you referred to the young people. I saw this picture of people lying in the streets as if they were dead because of climate change. We haven't quite done that around UHC, but, you know, that's basically what's happening. People die because they don't have access, because they don't have money, because they don't have good quality care. And they literally die today, here, now. So I think those are issues that one must discuss. I want to give the opportunity for about 3 short questions or comments, and then give Thomas the first opportunity to respond. Yes, please. Somebody's coming with a mic. If you're short, then we can take a couple more. If you're long, we have to stop you.
Yes, in Africa, life is short.
Yourself. Yeah?
Excellent panel. The key asks does not include anything on service delivery. We have been there with UHC for now since 2011 with IHP Plus. So as Thomas said, if we continue doing business as usual, there's not going to be any change. So the question to Ranieri Guerra is, how can WHO, the new WHO, move faster in advising governments to deliver health service to all its people? Because WHO is respected and listened to. And how can we move faster? That's 10 years, is very short time. Second, my comment to Jemilah and Thomas and also others is, why are you not using the power of the faith-based organizations and the professionals who deliver service, not professionals who put money into their pockets? Why are we not using them? As you correctly said, the volunteers walk the last mile, but faith-based organizations deliver the services in the most difficult areas. So those are the questions. And then lastly, the primary health care. Why primary health care? You can't deliver UHC without talking about primary health care. Why do we continue talking about UHC without talking about primary health care? Thank you.
Thank you. The lady in front of you, please.
Thank you. Indeed, excellent panel. I would like to ask to what extent you actually talk about access to health services and medication for free within this movement. Because even in this institution, there are students who cannot go to the doctor because they are not able to pay for the premium.
Thank you. And no more comments or questions? There was one. Where? She's coming. She's coming.
Thank you. I just have a quick clarifying question, if you would, Dr. Guerra, about, you mentioned just very briefly about innovations and incentives, and if you could simply expand on that a little bit so we understand where that fits in the system, please.
Thanks. So I'd like to start with Thomas, as I said. Maybe you can answer to some of those issues around the primary healthcare dimension and some of the challenges of really pushing the agenda forward.
Well, primary healthcare was where we started. You know, the Alma Ata Declaration on Primary Healthcare, this was the Bible which was given into my hands when I started to work for Medicus Mundi International, Medicus Mundi 20 years ago. And the understanding of primary healthcare is a deeply political one. It is healthcare owned by the people, done for the people and the communities, and it also includes the difficult questions on political and social determinants of health. And it discusses the role of the state. So universal healthcare coverage started much more technically and tends now to get back to this political and societal core of primary healthcare and integrating it into its language and into its asks. And that's a good news. I think I had many worries and concerns about last year's hype on primary healthcare, as it was also very superficially done. But at least some of the honesty of looking back at primary healthcare as a political call was back. You know, Alma Ata Declaration calls for a new international economic order. Final stop. This was the sentence. And we are far from that new order. We are still in a global economic disorder. And the tendencies both of neoliberal globalization and of national egoisms will not help us in getting to a better future. Faith-based sector, why not work with them? Yes, why not? But the answer is different in every country. Ask the answer of what is the role of civil society, of NGOs, of communities in health service. There is no blueprint. And sometimes the faith-based sector is on the side of the problem, and sometimes it's on the side of the solution. So look at the core of it, and don't talk for others, but just support them in their struggle for health at their place and in their country. At least this is what we try to do.
Thank you, Thomas. And of course, as you indicated, it's also very, very context specific. I mean, the reason Alma Ata referred to the new economic order was that the new economic order was on the agenda of the United Nations. And I believe actually came from the Brandt Commission. And that's, and that was a very political notion driven by decolonization and other political movements. That, now what we have from the United Nations is the SDGs, which are not as political statement, I would say, as the call for a new economic order clearly was at that point in time. But that is to be discussed. But I do think, this contextual issue of, how should societies be changed and in what direction to really let people participate and have equitable distribution is very, very important. Jemilah, you also wanted to comment on.
Yeah, I think it's extremely important to engage with a wide variety of civil society organizations, including faith-based organizations. In my previous life, when I was running the World Humanitarian Summit, the consultations, one specific group we targeted was actually faith-based organizations, because, in almost every country in the world, you will see that, it is the local church, the local mosque, the local temple. They are the ones who are the first places where people go to for comfort. But also don't underestimate the power of people themselves. It's actually people who are at risk and vulnerable. We've got to also engage with them. And this is why, we're really excited about this possibility of the country advocacy. And I think, I reiterate the contextual nature of this. If I can just touch on innovation, and I think that's going to be very key. We are already starting to experiment with innovative finance to look at ending cholera, for example. And we're realizing that actually it can be done if we start talking to people who we don't normally talk to. So we're looking at, developing outcome bonds and so on and so forth. So I think the same thing can apply in trying to achieve UHC as well. And, how we measure it is going to be very important.
Mr. Petry, political will Chancellor Merkel give a strong commitment to universal health coverage at the UN meeting?
I'm not the spokesperson of the government, but if I were, I would be a little bit hesitant to give you a very frank answer. But I think she has done in the past, and so there's a high chance that she will so, that at least her voice will be added to the event in some way or the other.
Thank you. Ranieri, you had concrete questions.
Yeah, for the next 2 hours, and please stay with us. What we can do. Actually, there is one thing that is still surprising me. Some 10, 15 years ago, we had a Commission on Macroeconomics and Health that came out with a clear case for health being an investment. Then we lost momentum, and now we are revitalizing that in the discussion with ministers of finance and with heads of state. So there is basically nothing new, apart from the fact that we have stronger cases now showing that health is indeed an economic investment, which is worth the financial space, which is often denied. We have some additional issues, though, some additional evidence that unless we drive the investment into what matters, even within the health system, we are lost because the risk of wasting money is just there. One particular obsession for me is to move out of the clinical environment into what is the public health goods and the preventive elements of a system, which are most of the time neglected because we take them for granted or someone else has to look after them. I mean, I agree that obviously access to medicines, access to services is incredibly important. But what about water? What about air? What about environment? What about fighting, and this goes into the disincentives to the private companies, what about disincentivizing the fact that environment is an easy target, although sometimes not voluntary target for several companies. And the health sector is most of the time called to put remedies in place which are extremely expensive, much more expensive than actually regulating the system in a way that makes sense for the health, for the collective health and the public health of all the people. Incentive side, fine. I give you an example, 2 examples. One, antibiotics. The companies are losing interest because antibiotics are coming quite cheap. The net result is that we have 3 molecules in the pipeline. At the same time, antimicrobial resistance is probably the worst challenge for health system survival in the next few years. Research and development around these areas may come only if public money comes into the picture with specific rules of the game. In other words, you access financial incentives if you agree to work under such rules. Second, we have innovative drugs coming into the market now for cancer, for instance, cancer treatment, as it was a few years ago for C. hepatitis. You remember, sofosbuvir and others. Extremely expensive. The estimate in my country is that it will take another 4 billion euros every year to treat a fraction of people who need treatment. The real issue here is the survival of our systems from a financial viewpoint. And the only way to do that is that we agree with the companies on a transparent system by which we negotiate price of medicines. This has to go into the rights. But obviously, rights-wise, the companies may not accept a discussion unless there is a financial incentive, unless there is a financial perspective that goes beyond the 1 or 2 years limit that some of the ministers of health may face. At the end of the day, what matters is the fiscal space. Fiscal revenues, the way we work around that. Why do we allow for ministers of finance to get revenues on the sales of tobacco, for instance, while at the same time the health sector is called to deliver services and to deliver innovative drugs to treat lung cancer? The cost is 3-4 times, and the cost is going to increase in the next few years.
Thank you very much. So this universal health coverage agenda is going to stay with us, I think, for at least till 2030. I think it will be very important to have frank discussions about it. I think it will be critical to have real political discussions about it, because again, if we look into the history of universal health coverage, the real difference was not really economic calculations and arguments. It was political calculations and arguments that led to change. And I believe understanding this political dimension and using it in a variety of ways will be critical. As Dr. Tedros says, it's really a political choice. And the push for that political choice, the accountability for the lack of that political choice, will be absolutely critical. So I'd like you to thank this panel. I'd like you to thank the team of the Global Health Center that prepared that, and thank the team of UHC 2030 that was a partner in doing this event. Thanks to everyone, and particularly to the panel.